I posted a Zoom, and that took another 45 minutes.
No.
So, just be prepared. It's our only chance though, so but like for example, I'm not going to do a lot on the hard, and there's certain things I'm supposed to cover more than other things. And so you may wonder, is there a rhyme or reason to my path through the material? And that's part of the rhyme and reason that there's certain things I'm supposed to cover. Okay, but this is our one shot. Here's the game plan. I think I'm going to do the quizzes just like I did last year, probably Friday night or Saturday. I'll see what I do.
Saturday or Sunday.
I'm still recovering from Thanksgiving food coma. Friday, leave the lab open late.
Yes.
I'll be a little bit involved with some other things from 1 to about 3:30, but I probably won't have my dissectors in there so that you can use most of the time, not distracted, and you can use that body. Friday, well, you can stay as late as you want as long as there's 2 people. I'm going to go probably around 4, but that's it, okay? Can't come in Monday, so just make sure you get into the lab if you need review before Friday. I mean, up until Friday, right?
Yes.
After Friday it's closed, okay? I'm going to set the exam up Monday. I don't know which group's going to go first. You guys have to figure that out. Wednesday will be a long day. Just be prepared. This is again our only time with this material. Okay. So, kind of big picture. We were thinking about the cavities in the body. You know, we can divide body cavities into a thoracic cavity and an abdominal pelvic cavity. They're separated by this muscular diaphragm. But there is no technical physical separation between the abdominal cavity and the pelvic cavity. So I'll say that. Some things that maybe might seem counterintuitive, the top of the lungs, which we call the apex. Apex means point. It doesn't mean always top. The apex of the heart is inferior, apex of the lungs is superior. You can see here how the apex of the lungs actually focus up into the neck, into what's called the root of the neck, above the first rib. Some of the organs in the abdomen actually are pushing way up underneath the lower ribs. And look at the liver here, under quite a few ribs. Maybe that's counterintuitive. Okay, everything else is sort of straightforward there. I'm not going to say a lot. So here's a view showing you how we're going to separate thoracic cavity from the abdominal cavity with this dome-shaped diaphragm. We're going to first kind of explore the thoracic cavity, and then we're going to go down here and explore the abdominal pelvic cavity. And there is no physical structure separating abdominal cavity here, color-coded orange, and pelvic cavity here, color-coded green. This is overkill. Yeah. We could, though, even though there isn't a physical separation between the abdominal cavity and the pelvic cavity, we could demarcate like a circumference that we call the pelvic inlet. Kind of did this actually way back, probably 3rd week, when we did the gluteal region. So if you go to the pubic symphysis, not pubic symphysis, right? The promontory, sacral promontory back here. If you go to the sacral promontory right back here, and then we're just going to draw a line in a horizontal plane forwards to the pubic symphysis. you would demarcate the pelvic inlet. There's no physical lid separating structure. Okay, anyways. Okay, one other comment. Two other comments. We don't have a physical separation between top of the thoracic cavity and root of the neck. That's good. That means structures can go in between there, like the larynx. Actually, at that point, trachea, esophagus, and then really importantly, at the bottom of the pelvic girdle, there is no bony structure holding up internal pelvic organs. So to prevent what we call prolapse, which is a movement of an organ to some place it doesn't belong, we're going to cover the bottom of the pelvic girdle with a muscular sling, which is called the pelvic diaphragm, and you can see that here. And that is a key set of structures that we're supposed to talk about in this lecture. Our presenters are going to talk about that on models and may or may not point out part of it on cadaver. Okay, so enough about the cavities, that's easy. So another set of structures I'm supposed to talk about are called the serous membranes. So there's three places in the body where we find what are called serous membranes. In all three places, there's typically two layers to these membranes. There's an outer parietal layer and there's an inner visceral layer, and there's serous fluid traveling between the layers. Serous, spelled S-E-R-O-S. You're not serous, dude, are you? Okay, so serous fluid. And so we got fluid flowing between these two layers, and so therefore the three places that we find these are places where internal organs move, and so friction is generated, and so that fluid is designed to reduce friction. So that's why we have serous membranes. So where are they? We've got pleura membranes surrounding the lungs. We got a pericardial sac. Surrounding the heart. And lastly, a really kind of complicated set of peritoneal membranes. Peritoneal. In the abdomen and going down into the pelvis. Okay, three places that we find serous membranes. In each of these three places, basically, there's an outer parietal layer and an inner visceral layer. And they're separated by a little bit of fluid. In all three of these places, if you have infection or inflammation, that can irritate these structures. So you can end up with pericarditis, pleuritis, etc. All three of these places, if you end up with too much fluid in between these two layers, then the structures that are moving, that they're surrounding, have to work harder. Imagine you have too much fluid in the pericardial sac, now your heart has to work much harder, right? If you have too much fluid in the pleura, your lungs have to work harder to get air, to remove air, whatever. It's a bad sign. So there's sort of similar clinical scenarios that can involve all three of these. Right. Pericardial sac has just one little additional nuance, okay? Which I guess we'll talk about in a second. If you take the lungs out of the body, here's like the lung. So we're going to slice through. This is the root of the lung right here, the hilum. Remove the lung, and you touch what you think is the surface of the lung. You're not touching the surface of the lung. You're touching visceral pleura, which is on the surface of the lung. So visceral pleura is like this, on the surface of the lung, and then it wraps out like that. See it? Okay. So this is visceral pleura. This is parietal pleura. and in between those layers is serous fluid. Does that make sense? Like one way people describe this is, say you have a balloon, and I'll do it right here, and you punch your hand into the balloon. Okay. So as your hand goes into the balloon, it takes some of that balloon wrapping with it. So here's your hand now. Okay. So your hand now is the lung. This is an easy way to understand serous membranes. And so this layer of pleura right on the lung is the visceral layer, and this is the parietal layer. Okay? And this fluid here. That would be the pleural cavity. Okay. Got it? So, this is the first place you can see the serous membranes. If you cut through the ribs and like reflect down the rib cage, which we've done on most of our bodies except the new one, you're looking now at not the pleural cavity, you're looking at the thoracic cavity. And the thoracic cavity is actually divided into two parts. So you got a mediastinum here in the middle, which is where we're going to find the heart, surrounded by the pericardium. You can see the pericardial sac here. So the center part of the thoracic cavity is called the mediastinum. This is the pulmonary cavities, which contain the lungs. Oftentimes people will call this the pleural cavity. It's really not, okay? That is a misnomer. It's the pulmonary cavity. And those lungs are right, surrounded by two layers of pleura. In between those two layers of pleura, that's the pleural cavity. It's like almost a microscopic space. You understand the difference? The pulmonary cavity is a massive space. Like the lung is this big. Okay. So to do that, you take a bone saw and you cut in the mid-axillary line, you cut through the ribs, you cut up here, and just flop down the rib cage, and now you have access to the thoracic cavity. Okay, and in this view from the side, you can see the relationship of the heart in the mediastinum to, for example, the diaphragm. That's actually an important relationship. The heart's actually attached. The pericardial sac, which surrounds the heart, is attached to the diaphragm. So the diaphragm is attached. Oh, look at that. See, this is why I only got to lecture to slide 45. You guys hate me? Gotta put an earring in there. There's the tongue. Yeah. Oh wait. The tongue has a. Yeah. What? Oh yeah, that's the second. Okay. Okay. Moving on. Slide 3. Okay. This is the only slide on the heart. Okay, so you might, I'm sorry. You could have whole lectures on the heart, seriously. So you're kind of getting shortchanged a little bit right there. There's only so much we can do. It's obviously incredibly important structure, really cool. The apex of the heart is the opposite direction of the apex of the lungs, okay? It's at the inferior angle. The heart is in relation to your sternum. Slightly, the apex is slightly to the left. So actually, 3 of the 4 valve sounds you listen to over here on the left side, okay? Because of that, it's not right directly behind the sternum, okay? So it has clinical importance. It's relationship to the sternum. And I should say, if you were dissecting, you actually wouldn't, the first thing you'll see is just fat covering the pericardial sac. Okay, so here we are. We just opened up the thoracic cavity, and then so two things actually. Okay, you have to dissect the phrenic nerve going to the diaphragm out of the fat covering the pericardial sac. People are often really excited to see the phrenic nerves when they open up the thoracic cavity. You don't see them. Okay, they're hidden. They're traveling here through the fat in the sac going down the diaphragm, and you have to remove the fat to see the phrenic nerves. We've done that in some bodies. Then you can open up the sac. Guess what? Once you do that, you don't see the heart. You see fat, visceral fat on the surface of the heart, like this. Then you have to, using blunt dissection, you have to remove that fat, and then finally you can see the coronary arteries. So here you can see a branch of the left coronary artery. This particular branch is the typical cause of a heart attack. It's sometimes called the Widowmaker branch. And right over here, you can see coming off the base of the aorta, the right coronary artery. But you don't see this initially, you just see fat. You gotta scrape away the fat to see the coronary arteries. Then on the top of the heart, you see the three great vessels. And so what I would say is when you're trying to orient a heart, first thing you want to do is you want to know what's the front, what's the back. On the front, okay, the great vessels have a particular sequence. So the pulmonary trunk is most anterior, aorta is in the middle, and then the superior vena cava, returning blood to the atrium, is behind it. Okay, so those are the great vessels. The apex is to the left, right here. So this is how I know this is frontal view. I also know this is a frontal view because I see this branch of left coronary artery and right coronary artery over here. There's some cute little ears on the heart. I bet you didn't know the heart had ears. These are called auricles. Here's the right auricle. Here's the left auricle. And what they do is we think, just add volume to the atria. The heart is a really cool, we have a dual pump heart. Not all circulatory systems are the same. Some organisms have open circulatory systems, some have closed. Little digression, I think it's cool. But you ever wonder, like, how do animals in Antarctica not freeze? There are fish down there that have antifreeze in their blood, like basically a chemical that functions like antifreeze. How freaking cool is that? But anyways, there's all different kinds of circulatory systems. Ours is a closed circulatory system, and not all hearts are the same. And there's a really cool little tangent. Sorry, you've noticed some Leonardo da Vinci pics on the front of my PowerPoints. I've always been a fan of Leonardo da Vinci. There's an awesome 4-hour documentary on PBS right now. It just came out, really awesome. Goes into his art and his anatomy. He actually, I didn't know this, he actually thought the heart was, as classical anatomists in antiquity described it, 3 chambers. Finally, when he did more dissections, he's like, no, there's 4. So not all hearts actually have 4 chambers, but ours does. Pretty cool. And so the 2 entrance chambers, like the entrance to a building, are the 2 atria, and then the 2 output chambers are the ventricles. And the right side is where deoxygenated blood is coming in. And the left side is going to send freshly oxygenated blood to the body. Okay? So left side is going to end up with oxygenated blood. And this is also a common misconception that people have about the heart. Sometimes they think, okay, it's right side of the heart works first. We return blood to the right atrium, we pump it into the right ventricle, we then pump it to the lungs oxygenate it, lungs bring it back to left atrium then pumps it into the left ventricle, and finally we pump it to the body. Wrong! Simultaneously, deoxygenated blood is being returned to the right atrium and oxygenated blood is being returned to the left. Simultaneously, it is a dual pump. It is not in series, it is in parallel. Really, really important, distinction. Some of you here are athletes, just because I know some of you might spend more time looking at the heart lab, which is cool if you want. You'll notice that the wall of the left ventricle is much stronger, much thicker than the wall of the right ventricle, and that's because you have to pump blood against gravity up to the brain. 20% of the blood in time is going to the brain, etc. But actually, and so in athletes too, there will be hypertrophy of the heart. It's a good kind of hypertrophy, but if you're not an athlete and you have a crap diet, which many people do have, unfortunately, the heart will also enlarge. And if you look at enough hearts and cadavers, you'll just see some humongo hearts, pathological hearts. Why? The heart has to work harder to pump blood against the resistance it's encountering now because of all the Krispy Kreme donut crap plugging in Doritos, plugging your vessels, right? So you can see hypertrophy for a positive reason and for a negative reason. Anywho, our heart is a dual pump, pretty cool. And there's little valves regulating flow of blood from the atria to the ventricles. We only want blood going in one direction, atria to ventricles. You don't want blood, when the ventricles pump, going back into the atria, be inefficient, right? You want this blood in the left ventricle just going to the body. If instead only 80% goes to the body, 20% retrogradely is pumped back to the left atrium, bad. There's eddies, you could have clots forming, you're not getting enough blood to the body. So these valves are pretty key to that, and we can close them with the chordae tendineae, which you could look for if you want. I see I'm already spending too much time on this. The heart's so cool. And some of you here, I bet, have murmurs that were diagnosed when you were little babies, your little kids, and those murmurs are due to, which are sounds of the valves closing abnormally. They're due to slight imperfections in your valves. Okay? Anyway, dual pump, 4 chambers, pretty cool. Right side gets deoxygenated blood, left side gets oxygenated blood, right side pumps to the lungs, left side pumps to the body. There you have it, people. The whole enchilada. Okay. Now, some of you have been wondering about Harry Potter and why I talk about Harry Potter a lot. This is why. This is Harry Potter's ligament. Right there. Ligamentum arteriosum. This is a cool little fetal remnant. Okay, little digression. Sorry. I'm going to do a lot today. It's my last lecture. Yeah, it's cool. You don't have to put up with me, right? The fetus, people, sorry, break the news, has collapsed lungs. Doesn't make any sense to pump blood to the lungs, therefore, and so don't, if we can help it. And there's a number of subtle variations in fetal circulation that make sure the heart in the fetus doesn't pump blood to the lungs. You might ask, well, dude, then how does the fetus get oxygen? The mother, okay, so one way is if some blood in the fetus ends up in the left ventricle, which in us is going to pump blood to the lungs. Okay, bad news in the fetus, but not all's not lost. Left ventricle is going to pump into the pulmonary trunk. That would go to the lung, but there's a little tube, a little connector from the pulmonary trunk to the aorta in the fetus. And so blood that was about to go to the collapsed lung in the fetus bypasses the lungs, goes to that little connector into the aorta, goes to the mother. Cool. And then right at birth, that little tube closes off, and we call the remnant of it a ligament, ligamentum arteriosum. By the way, we're going to use that if you're dissecting and in the bodies to find, here, vagus nerves coming down here. It gives off, like, one of my favorite nerves in the body. It gives off a branch that goes right next to Harry Potter's ligament, wraps around the arch of the aorta, and heads right back retrogradely up to the larynx, into the voice box, into your vocal cords. Yay, team! Current laryngeal nerve. Yay, team. Okay. Isn't that cool? Harry Potter! Harry Potter! That classroom down there is your door's open. My goodness, somebody's got to do that. You got it. Okay. Yeah. Technically, the pericardial sac kind of breaks the rule. I know I told you that the serous membranes have 2 layers. It's just, imagine there's 2 layers to the pericardial sac, and then we just add an outer, tough, fibrous layer. And so really, the pericardial sac is 3 layers, so just be careful. So, if in a cadaver, and you can see this in multiple cadavers, you're looking at the remnants of the pericardial sac, and you touch the outside of it, or I tag the outside of it, and I ask you what's the first layer being pinned, you're going to say it's the outer layer of pericardium, which is the fibrous layer. It's super thick. By the way, if you touch the inside of the sac, you're now touching the parietal pericardium. Follow me? You're gonna look at it and think like it's 1 layer of tissue. It's 2. Okay? And then if you touch the surface of the heart, you're touching visceral pericardium. So that's why we say pericardial sac really is 3 layers. Okay? And just I'm gonna say this again. If you were to open up the thoracic cavity, excited to see the heart, first of all, you're not going to see it at first because it's covered by the sac. You don't even see the sac at first because it's covered by pericardial fat. Okay? You don't see the phrenic nerve at first because it's running through the fat. It's fun actually to dissect it out of the fat. Might be doing that, Chelsea, or someone. Okay. Next semester. Hold yours. Here's the pleura. I don't want you to bother with like clinicians will name the parts of the pleura, like is it next to the diaphragm? It's diaphragmatic pleura, right? Is it next to the ribs? It's costal pleura. I don't think for us that's so important. Just so you're aware, we could get granular there. It's just pleura though. And this is that little visual analogy I was showing you, like some people have trouble like visualizing where's the visceral layer and parietal layer. Again, imagine you're punching a balloon, and as your hand goes into the balloon, it's dragging some of the balloon with it. That's the visceral layer. Okay. This is the parietal layer. And in between it actually is the pleural space, and mostly it's almost microscopic, virgin and microscopic, and it's a very narrow space with a teeny bit of serous fluid traveling through it. Not quite microscopic, but you know, virgin in it, right? Okay. All right. Okay. So the pleura, these serous membranes covering the lungs. The lungs are pretty neat. You know, if you ever get a chance to touch like an animal lung, like in a butcher shop or something, like freshly butchered, I don't know if any of you are hunters, it's pretty cool. Like it's really springy and elastic. Like if you punch into a lung, it'll make this indentation and then it'll just pop right back out. Which is important if you remember, at rest, when you're breathing, you only need 2 muscles to breathe. And you only need those muscles for inspiration. Expiration, you don't need any muscles to expire at rest. It is purely due to passive recoil of the lungs and some of the other structures involved in respiration, passive recoil, okay? It's a really cool structure and spongy. And if you look at enough cadavers and enough lungs, you'll start to see like clearly people who were smoking a long time. Tragically too, like even if you're not a smoker but you grew up in really polluted cities, you'll see the effect on the lungs. They'll look black. You know, like a little tangent. Two interesting, I think, tangents. 3, sorry. I grew up in LA. When I grew up in LA and I'd be playing in the playground, that sounds dumb. Okay, that's what you do in the playground. And I'd come home, I would have trouble breathing in deep because of all the pollution I was breathing in. Then we enacted all these air pollution, whatever regulations in LA. It's way cleaner in LA now. 2 more examples, one in China. Apparently, for whatever reason, they had a different industrial policy in the north and the south. So I forget which, but in one part of China they could use more coal, and the other part of China they could use less coal. Guess what? They started tracking longevity. They think there's a 5-year difference in longevity and lifespan in these 2 different regions potentially. that they're attributing mostly to the particulate matter that people are breathing in. Last example, Delhi, northern India. I've been there and the pollution's horrible. I've heard so bad though that a lot of people who have money, they just choose almost never to go outside. They have air filters in their house. They have special air filtrations in their car, air filtration at work. They'll go to grocery stores where there's air filtration. It's like dangerous to breathe outside. So anyways, my point is, by all these tangents, is like you can see the effect of that, the accumulated effect, literally visually looking at lungs. If you look at a lot of lungs, they should look pinkish. Anywho, okay, right lung for whatever reason has 3 lobes. Left lung has 2. I've looked into this. I don't think there's any functional difference having 3 lobes or 2. You know, it's just what we see. Okay, so there you have it. So they're separated, the lobes, by fissures. Okay, on the left lobe, I'm sorry, on the left lung, because the heart, remember, is slightly oriented to the left, there's a little cardiac notch that develops due to that little relationship with the heart. Think about the heart being right there. So there's a little notch. Remember, in the lungs, the apex is at the top, and they're actually poking past the first rib into the root of the lung, into the root of the neck. There's certain lung cancers that just affect the apex. Those are kind of interesting. They can affect, we just had that lecture on autonomic nervous system. They can affect cancers at the top of the lung, can affect the sympathetic ganglia, and then you lose sympathetic outflow to the head, start having trouble dilating your pupil, your eyelids droop, your pupils start to constrict because you can't dilate your pupils, you lose sweating in the face. It's called Horner syndrome. It's a really interesting thing because think about it. You're seeing these changes in this patient's head, so you're thinking it's clearly the problem's neurological somewhere up here, right? Like they can't dilate their pupil, they can't sweat in the head. No, the problem is lung cancer. It's pressing on the sympathetic chain, like the last place you would suspect, you know what I mean? It's a really interesting syndrome, Horner syndrome, because it can be caused by these weird counterintuitive tumors in places that you wouldn't expect. So one of them is like cancer in the apex of the lung. Okay, anywho, 3 lobes on the right, 2 lobes on the left. We could further divide the lungs into bronchopulmonary segments, and there's something like 10-ish per lung. You don't have to memorize that, but 8 to 10. These are clinically important. Like, let's say you had a tumor in your lung. Typically, the tumor is going to be in one of those bronchopulmonary segments. You can just take out that segment, and the rest of the lung will just be hunky-dory. And hopefully, that cancer hadn't metastasized already, right? So you can like take out a pulmonary segment from a lung surgically, and each one has its own blood supply. It's cool in that sense. You don't have to take out the whole lung. Okay, this is kind of neat. A few comments about the respiratory tree. So until you get way out to the periphery of this tree, so you're way inside the lungs, all of it's cartilaginous, okay? And so actually, because of that, you can't exert autonomic control on the diameter of the cartilaginous part of the respiratory tree. Follow me? Because the cartilage is really strong. You can't constrict it and dilate cartilage. That means, but we can, the autonomic nervous system can constrict and dilate the respiratory tree. It only happens way out in the suburbs, okay? Where we've lost the cartilage. Way out, way out, way out here. If any of you have asthma, and I'm not trying to pry, you might, carry an inhaler. You're basically carrying a device that squirts a chemical into your respiratory tree that mimics what the sympathetic branch of your autonomic nervous system does, and it dilates your respiratory tree. But it is not dilating your trachea, it's not dilating the primary bronchus, it's not dilating the secondary bronchus, people. It's dilating the non-cartilaginous part of the tree. Okay, division here, where the trachea divides into two primary bronchi, is at T4. I already talked about this in the previous lecture when we were thinking about the sternum. It's the sternal angle, right? Okay, so it's kind of clinically important. Anatomical T4. And where it divides into two primary bronchi, I want you guys to look at this in some of the cadavers. This is sort of interesting. Like, this is not, you know, just like a roughly drawn or poorly drawn image. It does look to me like the right primary bronchus going to the right lung looks different from the left primary bronchus, and that's because it is. The right primary bronchus is shorter, wider, and more vertical. Because of that, if you by accident inhale food, so food goes down your respiratory tree instead of your GI tract, it'll tend to go into the right lung, not the left. So the primary bronchi go to the lungs, and they're slightly different in orientation and anatomy. The secondary bronchi, there's 3 on the right, and there's 2 on the left. That's because the secondary bronchi go to the lobes. There's 3 lobes on the right. There's 2 lobes on the left. So there's 3 secondary bronchi on the right, 2 secondary bronchi on the left. Here's the question for you, because sometimes that's kind of like where we stop, and then we like zoom all the way forward to here. This is microscopic lung. These are called the alveoli. You know, unless you're Italian, they're called ravioli. Just kidding. Okay, so bad. Sorry, bad joke. Sometimes people think, okay, so like maybe, so Ernst just said there's a trachea, primary bronchi, secondary bronchi, maybe there's like tertiary bronchi, or like, I don't know what the word is for fourth bronchi, and then maybe we're here. How many branch points do you think there are? What'd you guess? 4? 5? There's more than 20. Upwards of like 25 branch points. My point, like from here, so first branch point, second branch point, third branch point, see what I'm saying? Fourth branch point, fifth branch point, sixth, you get the idea. So there is just this unbelievably convoluted, complex tree with millions of these alveoli, which is the terminal branches of the respiratory tree. These are covered with a membrane that's 1 cell thick, perfect for diffusion of gas. So it's at the alveoli where we inhale oxygen and we breathe out CO2. Okay? How is it that we do that? Due to partial pressure differences. So like add an alveoli. This is like an alveoli. Oxygen is driven in because the pressure of oxygen outside the alveoli is greater. Partial pressure than inside. Likewise, CO2 is driven out because the CO2 pressure is much, much higher in your lungs than outside in the atmosphere. Okay? So partial pressure difference drives things in and out. Okay? Pretty cool. So the site of gas exchange is at the alveoli. Okay. So here's where that primary bronchus is going into a lung. And if you look at a lung that's been taken out of a cadaver, you could look at this in the lab. You can feel the difference in texture between the bronchus and the pulmonary artery and vein. You'll just feel like, oh, that's definitely cartilage, right? It'll feel really tough. So I encourage you to see if you can feel which one's the bronchus and which is the artery and the vein going in there. And that place where the bronchus and the pulmonary artery and the vein are going in to the lung is called the hilum. It's called the hilum. It's called the hilum. Okay. All right. And all the stuff going into it collectively makes up what we call a root. So like if you look here, here's a lung, look at it from the side. One of the worst ever attempts at drawing a lung. And all the stuff going in forms a bundle. That bundle is the root. what's in the bundle? Pulmonary bronchus, pulmonary artery. Okay, okay. So let's say you're looking into the thoracic cavity. So this is the right side. Here's my heart. Middle. Okay. This is an important relationship I want you guys to know. There's two massively important nerves that you can see traveling vertically down in vicinity of the root. One goes in front of the root of the lung, one goes behind. So the nerve that goes in front over the root is the phrenic nerve. Let's go into the diagram. Okay, now I'm going to do the other one in a different color. I'm going to do a dotted so that you know this nerve is going to go behind the root of the lung. So there's another nerve paralleling the phrenic. It's going behind the root. And this is the vagus. So phrenic nerve goes in front of the root. Vagus nerve goes behind. You can see that here. Vagus nerve is going behind the root. This is posterior. Phrenic nerve is going in front. This is anterior. Okay. I'm not going to ask you to identify this, but you can see this, especially in kind of really fresh lungs in the cadaver. There are these impressions. It's so spongy, right, and elastic, the lung material, that there are these impressions you'll see in the lung. Like this is an impression made by the azygous vein. It's cool. It's cool to see these impressions. Here's an aortic impression in the left lung. Same thing. Here's the hilum, and all the structures going into the hilum form the roots. Same kind of stuff, right? Okay. Now, if you remove the lungs, we're going to see some cool things. So our presenters are going to show us some of this stuff. I sometimes call the right pulmonary cavity the blue side. I don't think I'm alone. Some textbooks too. The reason is you don't have the aorta over here, so you don't have red, oxygen-rich blood. It's mostly veins, so that's why it's the blue side. And there's a set of veins here that are kind of unique. There's no arterial counterpart. So this is the azygous venous system. Here's the azygous vein right here. Azygous. Azygous. And it arches up and dumps into the superior vena cava. So it's going to dump into the right atrium of the heart. So it goes like this. Azygous arches into superior vena cava, which is going into the right atrium. Okay? And this azygous venous system is draining blood from like behind the lung, the back of the rib cage, whatever, okay? The other neat things you can see here, if you remove parietal pleura and some deep fascia, is the sympathetic chain ganglia. So remember from my lecture, sympathetic chain ganglia run from the neck to the pelvis, but they're easiest to see behind the lungs. So here's the right sympathetic chain. Set of ganglia with these little interconnectors. But this set of sympathetic ganglia, they're going to continue all the way up into the neck. You're also going to see multiple cadavers, a nerve leaving the sympathetic chain and going kind of in a diagonal line like that, and you'll see little feeders into it. That is a splanchnic nerve. Does It's actually the greater splanchnic, which you can see. And really, you're supposed to pronounce it splanchnic. Okay. Splanchnic is like some old name for a visceral structure. No, I teach my students that, and like they tell me that they're always tempted to use that term like in rounds, and they feel embarrassed. So this is the chain, and then coming off at it at an oblique angle is a splanchnic nerve. Okay, what are the splanchnic nerves doing? They're going into the abdomen, and they're carrying sympathetic information into the abdomen. Okay. All right. Let me see where we're at. I don't think I want to know. Oh my god. Yeah. Okay. I'm not going to do that with you. Okay. Okay. This is the left side, which is sometimes called the red side. Because notice I don't see any azygous vein here, but I see this really beautiful thoracic aorta, which is filled with oxygenated blood. So this is the red side. Okay. And other than that, same kind of stuff. You're going to see a sympathetic chain over here. You're going to see a splanchnic nerve right there. Okay. Okay. You got to pronounce it kind of like you have Tourette's. Oh my God! I saw the best video. This taxi driver with Tourette's syndrome picks up this passenger who has Tourette's syndrome. She doesn't know it, and he starts saying, "Are you taking me to the right place?" Sometimes they'll it's kind of like Tourette's syndrome can have an explosive kind of verbality, and then she's like, "Oh my God!" And then they both start Touretting, and they just start cracking up. She's like, "This is the best ride ever." And sorry, I digress. The other thing with a lot of folks with Tourette's syndrome, sometimes they have the fastest minds that neurologists say they ever encounter. It's pretty cool. Okay. Sorry, little Tourette tangent. Oftentimes Tourette syndromes are more physical, they're not always verbal. And they'll describe the physical tic or the verbal tic as having the form internally of like this itch that they have to scratch, and the only way they can scratch is to let out the word or let out the movement. It's really interesting. And I've heard some say that there's some medications you can try because it's kind of a basoganglia disorder, and then the medications can help, but sometimes they'll go on drug vacations because they miss their quick mental cognition. Sometimes they're really witty, very fast jokes. It's cool. And they miss that on the drugs. Anyway. Okay, so this is another view of the sympathetic chain coming down here. And here's the splanchnic nerve coming off of it. Okay? All right. I know, sorry. I just spent many years working with folks with disabilities, so I think about it a lot. There's an awesome documentary called Tick and Shout, which is a play on Twist and Shout, and it's just about this conference of all Tourette's getting together and just like misery and hanging out. It's freaking awesome. Very good. Okay, so you're gonna look for this. Now, okay, pretty don't freak out about this picture. It's really beautiful, complex, but really what's going on here is there's 3 autonomic plexuses in the thoracic cavity. There's a pulmonary plexus, a cardiac plexus, and an esophageal plexus. And guess what? Each one of those gets parasympathetic and sympathetic nerve fibers. Guess what? I talked about this in my lecture last week. The parasympathetic component to all of these is vagus nerve, only vagus. Okay. Sympathetic is, coming from this system here that we talked about. And you can see this on a couple cadavers. I think body 6 in particular is great. You can see the esophageal plexus. It's really clear on body 6. You can see vagus nerve coming into the esophageal plexus. I don't want you to leave thinking that the esophageal plexus is just vagus. It's got sympathetic too. It's a mix, right? Parasympathetic speeds up digestion, sympathetic slows it down. Okay. Parasympathetic constricts bronchioles, sympathetic dilates. So again, like if you're using an inhaler, you're dilating, right? Okay. Parasympathetic slow down the heart, sympathetic speed up the heart. Okay, moving on. I've done this too much. Okay, just talked about that. All right. Okay, moving into the abdomen. See, like that's all we had. Just on the thorax. Sorry. When you open up the abdominal cavity, it's cool to do. This isn't what you see first. You don't see the intestines. This is what you see. You see this weird, funny-looking yellow-like thing hanging off the greater curvature of the stomach. This is the stomach. I like to call this funny, yellow-looking thing the omelet of the abdomen, or the greater omentum. It's actually the greater omentum. It looks like an apron. It's this fatty structure that's part of the peritoneal membranes that we talked about in the lecture. And you can actually flip it up like an apron, and if you do, you'll see more peritoneal structures. This is the peritoneal structure here that's suspending the small intestine. Okay, so the other cool thing about the greater omentum is we think it can move. How does it move? We think probably responding to chemotactic signals, so chemical signals, and it will like maybe move towards an infection and isolate it. Okay, it's pretty neat. Anyway, this is what you see at first. You see the liver, you see a teeny bit of the stomach, and then you see this weird apron-like greater omentum, which is part of the serous membrane of the abdominal pelvic cavity hanging around the stomach. Okay. If you remove it, you start to see more intestine. Next, if you haven't done anything else, you'll see, ascending colon, maybe transverse colon, descending colon. Sometimes you don't clearly see ascending colon and descending colon. The reason is that the peritoneal membranes in the abdomen they're complex, three-dimensional relationships, and some organs develop behind them. They're called retroperitoneal. And some organs are inside of them, like the lungs are inside the pleura, do you know what I mean? And so like the ascending and descending colon are actually retroperitoneal, so you may not see those initially. Anyways, so it's kind of like what you see at first. Okay. So the problem with the peritoneal membranes, and I don't know, maybe I'll change this after this year, but you guys have to do this. I'm not quite sure why I was told to really teach you guys so much detail about the peritoneal membranes. I can't imagine you guys doing a lot with this. PT students, but I was told to do this. I might change that. You're not going to be able to take advantage of that, though. So you're going to have to learn. Sorry. Okay. So, I don't know. Yeah. Okay. The problem with the peritoneal membranes is there's different words to kind of describe them depending on what structures they're holding up, suspending or surrounding. The pleura, they're just called the pleura. Pericardial sac, but the peritoneum takes on different names. Okay, that's what I think is the drag about this. So, okay, I'm going to kind of show you. So this is the stomach. Esophagus, and the stomach leads into the first part of the small intestine, which is called the, and you got to pronounce the small intestine, the first part, like you're from Brooklyn, this is the duodenum, okay? All right? So, I used to live in Brooklyn, so I can say that. All right, so, and I love Brooklyn accent, it's awesome. I can't do it well, but I wish. Anyways, okay, so, hanging off the greater curvature of the stomach, let me do it with a different color, is the greater omentum. Here it is, greater omentum. Okay. Now, running from the lesser curvature of the stomach to the liver. Here is the liver, people. This box. Running from the lesser curvature of the stomach to the liver is the lesser omentum. There it is, people. Okay. Suspending the small intestine is just the mesenteric spine. Suspending the small intestine. So this is your small intestine. Suspending that is the mesentery. Lastly, you guys, I'm sure all have a basic idea of the large intestine. The large intestine goes like this: ascending colon, transverse colon, descending colon, sigmoid colon, rectum. So, ascending colon, transverse colon, descending colon. Sigmoid means S, or curvy. Rectum. Anus. Okay. So there's a little peritoneal membrane that suspends the transverse colon. So here. So that's called the transverse mesocolon. And there's a little peritoneal membrane suspending the sigmoid colon from the abdominal wall, and that's called the sigmoid mesocolon. Okay. So really what these peritoneal membranes are doing is they're kind of doing two main things. They're suspending a lot of our organs in the abdomen and pelvis, and then they form a pathway for nerves and blood vessels and lymphatics to get to organs. So like, you want to get a nerve to the small intestine, you can travel along these membranes, right? Okay. You want to get lymphatics to an organ in the abdomen, you can use these, okay? Right. So, why I'm teaching this. Yeah. Let's not do these sacks. I don't think that's important. Sorry. Forget. I do want you to know, here's that gray omentum hanging off the stomach. Here's the lesser omentum going from the stomach to the liver. Okay. And you can put your finger under the lesser omentum, and there are these really important vessels. This is called the portal triad, right here. You could put your fingers under that. That's called the foramen of Winslow. It's a really interesting passageway. And surgically, it's important. Let's say you had to operate on the liver. If you put your finger like this under these vessels right here in the lesser omentum and clamp off those vessels, you just blocked off blood supply to the liver, and you can now operate on the liver and you're not going to bleed to death. Okay, so really important kind of clinical space. Okay, so now here we've removed the greater omentum, right? The greater omentum's hanging off the greater curvature of the stomach. Here's the greater curvature of the stomach. See it? Okay, we remove it. Now you're finally seeing kind of more intestines. This is all small intestine right here. There's 3 parts to the intestine, and this is how I remembered it initially. You guys know, I don't know if any of you are into like stocks or investing or, okay. You know the Dow Jones Industrial, it's like a collection of really big companies that are worth a lot. Okay, so Dow, duodenum, first part of the small intestine. Jejunum, Dow Jones, second part. Dow Jones Industrial, ileum, third part. Okay, so 3 parts of the small intestine. And the third part, the ileum, will talk to the ceca, which is the beginning of the large intestine. Like in ungulates, like in cows, the cecum's really big, really large. In humans, not so much. Hanging off the cecum is where we have the appendix. Okay. So 3 parts of the small intestine. Okay. All right. So here's the first part of the small intestine coming off the stomach. This is duodenum. Notice there's a really cool relationship of the duodenum to this yellow structure, which is the pancreas. It's like you're putting your fist into a glove again. So, but this time your fist is the head of the pancreas. So the duodenum wraps around the pancreas like this. This whole thing's the first part of the small intestine. This is the duodenum. And why this is an important relation? By the way, this is behind the stomach. So like another thing that people get confused by, they're in the abdomen and they see the stomach. They're all cool. Like, where's the pancreas? It's behind. It's retroperitoneal. It's behind the stomach. Okay. So there's a little tube in the pancreas, and it connects right here to the duodenum. So the pancreas dumps digestive enzymes into the second part of the duodenum. Right there. Okay, so that's the pancreatic duct. It's actually going to meet up. The bile duct. Coming from your gallbladder. So right here, we're actually dumping into the duodenum pancreatic digestive enzymes and bile. We can't, like if you ever put butter in water, like for a soup, the butter will separate from the water. So we wouldn't be able to absorb fat in our meals unless we added bile to the digestive food. So that's why we're making bile, so we can digest and absorb fat. So it ends up being a dual little passageway here. Pancreatic duct, digestive enzymes, and bile via the bile duct, dumping into this first part of the small intestine. So this picture is a little bit off. Really, you do not see the pancreas at first. It's behind the stomach. That's clinically important if you have like a really bad ulcer. Acid in your stomach can eat through the wall of the stomach. And guess what it's going to do? Where's the acid going to go first? To the pancreas, like right behind it. All right. Let's take a break. Yeah, now I know why I already made it to slide 45.
Yeah. Come on.